Welcome to the WMed Specialty Spotlight Podcast, your virtual mentor for choosing a medical specialty and planning a career in medicine. On this podcast, we probe practicing physicians with questions about their specialty, the decision algorithm that helped them determine that the specialty was right for them, and then for advice about long-term career planning, irrespective of the field they went into. I'm your host, Dr. Biren Shah, WMed Assistant Dean for Career Development. Before introducing today's guest, just a quick reminder that selected show notes for this episode and all episodes can be found on our website at wmed.edu/specialty spotlight. If you'd like to support this podcast by sponsoring an episode or a physician interested in volunteering to be a guest on WMed Specialty Spotlight Podcast, please email me at bren.shaw@wmed.edu. The specialty of today's show is physical medicine and rehabilitation, and the physician here to tell us about it is Dr. Rebecca McConnell. Dr. Rebecca McConnell is a board-certified physical medicine and rehabilitation physician with Bronson Healthcare Services in Kalamazoo, Michigan. She is also a board-certified physician with the American Board of Electrodiagnostic Medicine. Dr. McConnell is a graduate of West Virginia School of Osteopathic Medicine in Lewisburg, West Virginia. She completed her traditional internship with Altoona Family Physicians in Altoona, Pennsylvania, and completed her physical medicine and rehabilitation residency at the University of Michigan, Ann Arbor, Michigan. During her residency, she did an integrated fellowship in medical education and received the Peer Teaching Award. She became a clinical instructor with the University of Michigan, running an inpatient and outpatient clinical practice in complex medical rehabilitation and musculoskeletal rehabilitation while working with medical students and residents. Dr. McConnell completed an International Research Fellowship from 2019 to 2020 with the Università di Torino in Torino, Italy. Her clinical teaching and research interests include medical education, chronic pain, musculoskeletal rehabilitation, and technologically enhanced rehabilitation strategies. Dr. McConnell's primary clinical interests include electrodiagnostic medicine, non-interventional spine, and chronic and centralized pain syndromes, including fibromyalgia. Additionally, she is committed in mentoring medical students aiming to enhance their understanding of pathology as well as a career path. So without further ado, Dr. Rebecca McConnell. Dr. McConnell, welcome to the show.
Thank you for having me, Dr. Shaw.
Well, thank you so much for taking the time on a weekend to talk to me about the specialty. And it's a specialty that actually myself, I really don't know well at all. So before we dive right into the questions, you heard me read your bio. Is there anything you'd like to add or maybe perhaps, take us to a time before medical school and walk us through your decision to go to medical school?
Sure. So I went to college thinking I'd never take another math or science course ever again. I got all my AP classes done and in, and I majored in philosophy. But as I was going through that major, I realized it didn't really help anyone. Except for maybe my understanding of the world at that time. During college, I started going to a technical college nearby at night and got a massage therapy license. And through there, I just recognized that the human body is probably, just is the most amazing thing ever. And from there, I ended up minoring in chemistry, kind of getting my prereqs in order and things like that, because the human body is just incredible. And massage was great because you're looking at the body structurally, but the language of massage therapy and a lot of the alternative, complementary, holistic treatments out there kind of devolve at some point to language that didn't really resonate with me. So kind of more of the spiritual, esoteric, chi lines, all of these things I have the ability to speak of and communicate with patients about, but it didn't resonate with me because I'm thinking, but what if it's just all structural? What if it's all chemical? And I really just resonated with that and needed to take it a step further. So I always loved school, and massage was actually my bouncing point into medicine.
Wow, that's really interesting. I want to now transition to the first part of the interview where I basically ask you to tell us everything about the field of rehabilitation or PM. Let's just do it easier, PM&R. And the way I'd like to start off is by reading you a description of physical medicine and rehabilitation, or PM&R, from Careers in Medicine website, which is hosted by the Association of American Medical Colleges. And then I'll ask you what you think about it. And so here it goes. Physical medicine and rehabilitation. A specialist in physical medicine and rehabilitation, also called physiatrist, evaluates and treats patients with disorders or disabilities in the muscles, bones, and nervous system, including neck or back pain, sports and work injuries, stroke, brain injury, spinal cord injury, spasticity, and other disability or disorder that affects function. A physiatrist may lead a team of medical professions to help patients improve their physical, psychological, social, and vocational function, and are dedicated to the whole person, including treating pain, restoring function, and improving quality of life. Treatment modalities may include medications, injections, therapeutic exercise, electrodiagnosis, and any equipment required for daily activities. So how much of that do you agree with? What would you add or subtract to ensure anyone listening was well informed of the practice of PM&R?
I agree with all of that, but I'm going to simplify it a lot. I'm the primary care of pain and disability. All of the other things that's listed in there, it's one of the reasons why I love this field, is because there's always something to do and improve, because it's basically three things. One, can you improve the body? Body, mind, can you improve the structure and the chemistry? Mm-hmm. Two is, can you improve the environment? So that's where the braces, people around you that know how to help, the wheelchairs, the robotics, the virtual reality systems. So one is the body, two is the environment, and three is sometimes people's disabilities, illnesses and diseases are chronic. And that third piece is all about improving acceptance and coping. Mm-hmm. So physiatry is the practice of managing pain and disability with those three aspects. And no one can optimize all three aspects all at the same time. We're always in a constant process working on it.
Well, that's great. I think you really simplified it a lot better than the careers in medicine, but that's wonderful. So I know you're in, and quite often I interview physicians that are super specialized. And so in this kind of interview, I'd like you to put on the hat of a general physiatrist. What does a typical weekly routine look like for you? And you can change that to whatever time frame that's conducive for your answer, whether it's daily or monthly. And what are the common conditions that you see as a physiatrist?
So the common general picture. I am slightly subspecialized, but I still see a lot of the general population because I'm the only physiatrist taking patients in the county of Calhoun County next to Kalamazoo. So while most of my patients, and I only do outpatient, I'd say about probably close to a 50-50 split of physiatrists who go outpatient versus inpatient, and then there's a mix. And so my clinic is all outpatient, and I work primarily with the back surgeons here, and I do non-interventional back and spine care. So kind of the pain and disability from back pain. However, I have this special interest in fibromyalgia and chronic pain syndromes. So I see about a quarter of my clinic is that. And then I have a smattering of general rehab patients. So I have a few stroke patients, debility geriatric patients. I have some multi-trauma patients with breaks and fractures and traumatic brain injuries from work injuries and motor vehicle accidents. So that's my clinic. It's varied, which is pretty fun. And then from my procedural aspects, almost close to half of my time, 40% of my time is spent doing EMGs, which is a completely different aspect of my brain power because that's a very technical study where I get to zap people and poke people with needles and see how their nerves are doing. And so it's very technical and precise, and I'm not directly involved with their patient care. I'm providing a service just like radiologists provide that service of double checking on an image and seeing what's found and what disease process could be going on. So that's my mix. So I typically get to the office around 7:30 to prep for my first patient at 8 and kind of do inbox messages. My last patient leaves by 5, and I usually have a couple hours of notes to do, 0 to 3, depending on how my day goes. I'm in a really nice situation now where I don't have call, I don't do nights, I don't do weekends. So nice. My notes are really extensive because I work with a team, so all the different therapists that I work with, and I'm a specialist, so I'm constantly trying to let other people know what I'm thinking and how I'm thinking it. So there's coordinated care, but it's a pretty sweet gig with outpatient.
No, I mean, that's a wonderful quality of life. Would you say that in general, I know that your specific situation, no nights, no weekends, is that typical for a general physiatrist?
It's not typical, but it's always possible. And I say it's not typical because, again, probably half or so are on the inpatient wards. So you can kind of think about it like internal medicine, where some internal medicine have clinic, some internal medicine go to inpatient. And so the inpatient side of things, you have kind of a little bit more of the possibility of a little bit more shift work and things like that. And, you know, when someone's in the hospital, they need a physician on call all the time. So there's certainly a lot of my colleagues do have nights and weekends call. It tends to be a little bit better than I am because sometimes rehab physicians kind of work it out and coordinate with IM to cover nights or weekends because there's less dedicated rehab care during the non 9 to 5 hours when therapists are also working.
Now, you kind of touched upon, the specialty in terms of differences, in terms of setting inpatient, but I kind of wanted maybe if you could elaborate more, how does the practice of PM&R change between, academic versus private practice, suburban versus rural, maybe military or government, and perhaps maybe international?
inpatient versus outpatient is just one of the biggest things. So inpatient, what that means is that once someone is out of the acute care hospital and it's clear that they are going to live, rehab hospitals then try to ensure that they live while living the best possible life that they can. So the rehab hospital is a jumpstart program to re-entry back to life. So the rehab hospital, it's a patient population that tends to be able to tolerate more than 3 hours of therapies a day. They need specialist care still. And there's a reasonable expectation that their life will be dramatically improved at the end of their stay. And their stay could be anywhere from 1 week to 3 months. Usually it's less than a month, but depends on the circumstance. Those folks are taken care of, and when I was doing it, I was taking care of complex medical patients. So spinal cord injuries, severe traumatic brain injuries. I was doing a lot of amputee care and rehab from organ transplant, liver, heart, lungs. So people who need a lot of coordinated care. So that's a huge difference from the outpatient realm where it's just clinic and you know who's coming in for the day. Inpatient is just a whole nother world. From an international standpoint, it's very similar. Not all countries have physiatrists. It's still a less known specialty, as you are aware. But they do exist. And the practices in Italy when I was there doing research were really similar to here with the outpatient, inpatient realm, with the outpatient being more follow-up of those severe injuries from the inpatient world, but also a lot more musculoskeletal based injuries.
Okay.
I don't have anything to speak of as far as kind of the military, non-military background. I have some colleagues who did military PM&R and they're back at the VA with that, and it's very, very similar. Inpatient with military and non-military, except the VA's pace is a little bit calmer than private practice or academia. And then academia, your other question, academia versus private practice, right?
Yeah.
No change in patient care from what I experienced. You know, if you're inpatient, you're outpatient, it really varies with who you see, but it can be the same either place. I love academia because I love teaching. I like talking. I like research. All of those things are wonderful aspects. The clinical part of academia was actually harder for me than private practices, because with academia, you have a much larger ship to steer, a lot of more bureaucracy. It's less mobile. And you don't have control over your schedule, your personnel, the people that are around you that are supposed to make daily life a little bit better and easier. Whereas private practice, especially right now, I love who I work with. And even though I don't run my own practice, I don't do the hiring, firing, it's a smaller ship. And I do have control with some of how things are run to make it a little bit smoother and easier. So that part is nice. And I enjoy where I am and have enjoyed being kind of on the teaching realm as not full faculty because it's a choice now, which is nice.
What do you find most exciting about PM&R, and what would you consider to be the mundane part of your specialty?
The most mundane part and kind of frustrating, insurance. And I guess that would be a a common thing for most people. I think I deal with it a little bit differently than some other specialties because I am working with more workers' comp
Hmm.
and auto cases and people who are going to get independent medical evaluations. And so I've been called a few times by lawyers to give depositions about who should pay for what, because was this prior to their accident or post their accident? And that's the extras that I don't particularly like. And it just kind of drags on because I love patient time, like face to
Hmm.
face. When I'm in a room, it's great. It's kind of all those little extras. And that part for me is an extra that I could absolutely do without.
And what would you say, as far as the biggest challenge that's facing the specialty, and where do you predict your specialty of PM&R to be like maybe 10 or 20 years from now?
I think I'm going to be a broken record with this because I was hearing the same thing when I was choosing this specialty as well, is that no one knows about us.
Yeah, yeah. No, it's true. I mean, it's one of those specialties that doesn't come up very often in discussion with medical students when I have conversations. But it's a fascinating, when preparing for this interview, learning a little bit about it, I was, amazed. I mean, of all what you do. And so, yeah, that's probably the biggest challenge is I don't know if people know about the specialty of PM&R.
There's a lot of overlap with other specialties.
Hmm.
So every physician in one way, shape, or form is dealing with pain and disability. It just is.
Yeah.
Um, we're just more of a centralized source for care in this realm. And because there's so many subspecialties within our
Hmm.
group, one physiatrist is going to do something completely different than another. So it's not like, okay, I have a headache, I need to go to a neurologist. Okay, I have chronic constipation, let's just, do the primary care workup and then go to GI if that's still not working. It's harder to have that algorithm because you actually need to know what the physiatrists in your area do.
Yeah. Yep, you're right. And you touched upon it that there are some subspecialty areas within PM&R. Can you touch upon like what are those subspecialty fellowships after
Yeah.
PM&R?
So subspecialty fellowships, and I apologize if I'm not going to say them all, but pediatrics is one.
Oh.
Pediatric
Hmm.
rehabilitation, so pediatric hospital, cerebral palsy, developmental disorders, amputations in pediatrics, all of those
Hmm.
aspects with pediatric rehab. Pediatric rehab is fantastic because your whole goal is to help someone play better.
Hmm.
That's it.
Yeah.
So pediatrics, then you can go kind of the entire opposite direction and do cancer rehab.
Oh, okay.
And so you work with HEMONC and work on optimizing function and environment for those folks as well, and kind of in the more palliative realm, including the more palliative realm. And then traumatic brain injury fellowship, spinal
Mm-hmm.
cord injury fellowship, spine interventional fellowship, so the people who are doing spinal injections,
Hmm.
sports medicine fellowship, so more of the ultrasound guided injections
Okay.
and sports sideline people.
Oh, okay.
You have regenerative medicine fellowship as well, and so
Hmm.
that's the stem cell treatments. That's
Oh,
kind of
okay.
latching on to the musculoskeletal sports medicine group
Oh,
too.
okay. Wow.
So
Yeah.
there's quite a few out there
Wow.
that that are kind of developing as well.
That's wonderful. Wow. And so where do you predict the specialty to be 10 or 20 years from now?
It's hard to say. I think this specialty is slowly getting more recognition.
Hmm.
which is wonderful. And I think our specialty has been pretty good and diligent as far as keeping some of the physician only tasks to physician only. And some specialties have been better about that than others, than having the advanced practice practitioners kind of taking over. There's pretty strict guidelines still in the inpatient realm of what those providers are able to do and not. So it kind of secures physiatrists as I guess top dog in that.
Yeah.
And that's not true in some other specialties. So 10 years from now, I hope I'm going to be doing exactly what I'm doing now with slightly more recognition, and my local group will know exactly what I do.
Yep. Well, I want to now transition to our second part of the interview, and that's kind of where I ask you to tell us how you decided to go into the specialty and that what made you decide that PM&R was the right specialty for you. So, can you kind of walk us through as far as how you came to realization that you wanted to go to PM&R, when that aha moment was, or any struggles that you may have had when you were thinking about specialties?
I was undecided for quite a while, and I actually had an extra year to think about it because I did a graduate teaching assistant program for a year in my medical
Mhm.
school to help pay for it.
Okay.
And so I had a little bit of extra exploration time that some of my colleagues didn't have. I really liked a lot of my rotations. And I think
Hmm.
that's one of the reasons that I was pulled to PM&R. That's one of them. So I really liked orthopedic. I really liked orthopedic spine, geriatric medicine, and psychiatry, which is so incredibly different, right?
Yeah. Yeah.
But to me, the coordination of all of those things kind of into a specialty where I wasn't having to deal with absolutely everything a patient had wrong,
Hmm.
but still being able to kind of take the whole person and focus in on that function piece, focus in on how you can live better.
Hmm.
And you have to have and like all of those aspects to be able to coordinate that with someone. And
Yep.
so liking everything kind of helped me decide that physiatry was the one that I liked best, I guess.
Oh, that's great. Did you
um,
have any head-to-head like between another specialty, or you kind of gravitated toward PM&R and you kind of realized that was it, or was there, a decision making between another specialty?
I would say the closest runner up for a moment was anesthesiology. And I say that because the other part of kind of my decision making was what I like to read about. And you know, I did well in school. I like school. It's my first career choice, but I loved reading about pain and pain psychology and the neurophysiology of pain. So when I finished those lectures, I was still thinking about it. Whereas when I finished a lecture about, you know, the renal system, I put it aside and did something else with my day. Yeah, it's what I enjoyed thinking about and just being curious about. So, anesthesiology does a lot of pain medicine as well. But then the thought of most of my practice kind of getting through the anesthesiology residency of just having someone be asleep with me just didn't make much sense. I think I'd be talking to myself a little bit too much.
As far as I want to make sure I get this question in, and that is the third year question. If you were a third year medical student undecided on the specialty with limited time remaining before residency applications were to be submitted, what do you think would be the fastest, highest yield route to make the decision about the specialty?
If at all possible, go to a conference.
Hmm.
and go to a head-to-head conference of the ones that you're in between, because those are the people who are going to be your colleagues, your support, your mentors for the rest of your career, and
Hmm.
see if you fit, see if you work well. There's a reason why we all have stereotypes in medical specialties,
Yeah.
and we do tend to stick a little bit with our own at times, and you don't need to be conforming to the rest of the group, but you
Mhm.
want to feel comfortable.
No, I would certainly agree with that. You know, as far as away electives, do you feel like away electives in PM&R is necessary?
Yes. So because it's not part of your curriculum. So
Hmm.
if you want to go into PM&R, if you're interested in it, you need to have a PM&R rotation on your application. And it shows that you're there for PM&R, and not there because you wanted something else and PM&R is your backup. So
Hmm.
it needs to happen.
Would you recommend doing a home rotation in PM&R before doing an away rotation in PM&R?
It's not necessary, because we know, and admissions in academics know that PM&R is not talked about very much and is not available everywhere.
Hmm.
So it's not necessary that you get multiple in, but making sure that you have at least one, maybe two, but you need one really good rotation. And since there's so much crossover with PM&R and other specialties, having PM&R in mind when you do those other specialties is still important, and you can learn a ton from all of our other colleagues in all of these other fields. So in cardiology and in pulmonology and neurology and in all of the surgeries, you're still
Hmm.
learning about rehab, you're still learning about the next steps for the patient. So doing well in all of them and having at least one really good solid PM&R experience is baseline.
Okay. Okay. And how important is research or scholarly productivity important in matching into PM&R?
It's not very important. So um, it's a it's an extra boost to anyone's resume, period.
Hmm. Yeah.
um, and there are some groups, some residencies who are definitely more research minded than others, but it is not a prerequisite to want to do that or show that you love it to
Okay.
get the specialty.
Okay. And is there anything else you would recommend a student should do to be a competitive applicant for PM&R?
Involvement in the rehab process if you can. I think volunteer experience is also pretty important, with the application, again, because we're not, we know that PM&R isn't everywhere. So making sure that you are a team player and volunteer experience helps show that
Hmm.
is kind of a more important aspect from a resume building standpoint, and making sure that if you want to do this, that you're doing it right. Because I, even outpatient where I'm kind of separate, I talk to the primary care physicians on a kind of regular basis. If there's something that we can coordinate, I reach out to the other specialists that the patient's on board with. I walk over to the therapy gym a couple times a week and talk to their therapist, even in the outpatient realm.
Hmm.
So there's a lot of teamwork and coordination that goes into that, and anything that builds your resume in that realm can certainly help.
Is there any resources that you would recommend a student that is interested in PM&R to learn more about the specialty or gain greater insight?
There's a couple. professional organizations. The main one is the American Academy of Physical Medicine and Rehabilitation, the AAPM&R. So they have some resources, and they have a student day as well for their conferences. So that's an excellent resource.
Okay. And we'll make sure we put that in our show notes on our website. Any other resources, or that pretty much it?
That's the main one. Yeah.
Okay. Okay. No, that's great. I want to now transition to the third part, and that's kind of more advice on long-term career planning, irrespective of the choice of specialty. And so if you could do it all again, if you could go back and do it all again, what would you do differently, and what would you do the same, and why?
Probably differently is I would have wanted to do a different internship. My internship was very difficult and a little malignant, and that I think is calming down now and hopefully improving in a lot of aspects. I think people are a lot more in tune and knowledgeable that the rules should apply to everyone in the nation and work hours and things like that. But just having and trying to look for places where people are kind sometimes is more important than looking for places that have this great academic rigor, and you're going to work really hard and you're going to learn a lot. You want to work hard. You're going to learn a lot. If you care about people, if you care about doing well, if you care about the person in front of you, you are going to work ridiculously hard, and you're going to continue to work hard and work harder. And you don't need to be around people who are not nice to do that. So look for kindness and keep looking for kindness.
Yeah.
And work
Well
hard.
said.
Yeah, and then work hard.
Yeah. No, that's great advice. What is a career mistake that you've seen other physicians make?
I'm going to say it because I think I almost made it. Don't be scared to do something a little untraditional. I after my residency, I did a year in academic medicine, and that first year as an attending was really hard. It was another transition. It's another hoop to jump through. Just like going to undergrad is a hoop to jump through and getting used to it. Going to medical school is a hoop to jump through. Getting into your clinicals is a hoop to jump through. You'll have all of these hoops, these big shifts in your life where you're having to kind of change things up a little bit. And my switch to attending hood was hard. And I thought that if I didn't stick with it, then I would be less respected in some way. And instead, I married a wonderful person who needed to work in Italy for 2 years. So I left. And I had a year and a half, and then turned into a little over 2 years because of COVID, where I was in the medical field doing research, but I was kind of refiguring out who I wanted to be. And there were some naysayers who said, oh, this is going to be so hard to get back in. This is going to be so challenging. I did, and especially as a woman, with the idea of, balancing kids and taking time off and things like that, it's all poppycock. You can leave and come back. It's okay. Yes, It's absolutely scary. But sometimes, this is my career. I love what I do. I think about it a lot. I take extra time to do it when I feel I need to, when I want to. But sometimes it's just a job. Take care of yourself with that.
Yeah. Sometimes you get so wrapped up you forget about taking care of yourself. That's first and foremost. But I want to now get to another question, which is, what is something that you've seen another physician do well that has made you want to emulate it?
I'm an academic at heart. I'm a student first, and when I was going through training, I always loved seeing the people who were just constantly learning. And when I was going through training, you're just fire hose of information.
Yeah.
And it's like, how in the world are you doing all of these extras as an attending, as a teacher, putting on an extra podcast while clinical duties, and
Yeah, there you
how are you
go.
doing all of this stuff? And as a student, I was just like, wow, I want to be these people, but my gosh, I'm going to burn out, and I'm never going to be like this. I'm never going to be this cool and this good and have all of these aspects of my career and my life and still feel fulfilled with things outside. And it's interesting when I have some students and I have some residents now, and I'm telling them about like this article I read last night that I thought was interesting. I'm like, oh, it just comes naturally. Like if you care and you find something you love, it just kind of comes naturally because it fulfills you, not
Mhm.
because you're trying to strive to be this mentor person. It's like, okay, self first, self-care, self-love first, and then if you find something that you love, you just latch onto it, and that's who I wanted to be, and I didn't actually try to do that, but every now and then I catch myself being that person again. I'm like, wow, that's cool.
Yeah, that's great. What is the one thing that you're struggling with or lamenting about your career today? And what are you doing to remedy it? And what would you encourage a medical student to do right now to help avoid this problem entirely later?
I take too long with my notes. I always run over. My clinic is always behind. I'm always apologizing to patients. This is an issue with me, and it always has been. I like staying in the room with someone, and then when I'm out, I'm like, oh my gosh, I have so much work to do. And I think that's my personality in general, and again, how I find fulfillment. And some things that I wish I'd kind of known up front is, it's okay to be a little bit slower and to keep experimenting with tools to kind of
Mhm.
make yourself faster. Get mentors, try doing dictations, use templates, and keep experimenting. Like it's
Mhm.
not done, and keep going forward with that. And then the other part, and I think it's the part where I've kind of come to, is that I need to just be okay with that too.
Mhm.
And I need to, again, make my body, make my mind work as fast as I can possibly make it work. But part of it's my environment and making sure that I am choosing a career and a group around me that kind of supports that and is okay with that.
Mhm.
And having at least a little bit of acceptance that I can go faster, but I don't feel like I'm going to do a good enough job if I go faster. And so, how can I make this work the best it can?
Yeah. Well, that's great advice. As far as for a radiologist, same thing, kind of, take the time to read a case. The quality counts, not the speed in terms of, potential making errors. So, no, I get that completely. Um, I want to ask this next question. I always ask this question to our guests. What is one book, medical or non-medical, that you think every person pursuing a career in medicine should read?
Can I give you two?
Yeah, you can give me two. Yeah.
So, one is Never Split the Difference by Christopher Voss.
Okay.
It's a book on negotiation. He does a really good job, and it's a fun read. It's a quick read
Okay.
on getting the most out of your negotiations. And this can be in relationships, with personal relationships, with your patients, with your job, and it's completely non-medical. That's a
Okay. Yeah.
nice one. And then the other one is The Body Keeps the Score by Bessel van der Kolk. And this is about trauma-informed care
Mhm.
and EMDR treatment in particular. But in the realm of chronic pain and disability, and everyone is going to deal with some chronic pain and
Yeah.
disability in their
Yeah.
careers. This one talks about how trauma and our psychological aspects change how our body feels.
Mhm. Okay.
And having some compassion for that aspect and going in with compassion can make a huge difference in how you feel about some of these patients and how they respond to you too.
Okay. Okay. We're going to put these books in our show notes so that all our listeners will have that information. Um, so, Dr. McConnell, is there anything that I haven't covered that you want to make sure our listeners know about the specialty of PM&R?
Join.
There you go. Well, of course, to our listeners, that especially the WMed students, they can obviously reach out to you. And now you're the faculty advisor for the student interest group, PM&R, and so that's wonderful. Um, well, Dr. McConnell, it's been a pleasure having you as a guest on the WMed Specialty Spotlight, and so thank you for that. For everyone listening, we'll wrap up the show with that. Well, I hope you enjoyed the conversation with Dr. McConnell. For the resources and other tidbits that were mentioned in this episode, you can find them in the show notes on the WMed website, wmed.edu/specialty spotlight. If you liked what you heard, please share this episode with your fellow medical students, especially if they're having some career anxiety. It truly is my hope that these conversations with physicians who've been there and done that will help you move forward with your own career choices. For any questions, or if you'd like to reach out to me for any reason, which I encourage you to do, you can do so by emailing me at bren.shaw@wmed.edu. But until next time, take care.